All right, everybody. I have a repeat guest today, Dr. Emily Levy. We recorded a few weeks ago and realized that we just had so much more to talk about. So she is back with us today. We're going to do a deep dive on TMD, and she's going to tell us what that is. And then if we have time in the end, we have a little something extra we want to talk about. If we don't have time, then she's just going to have to come back for a third time. So thanks for being here, Dr. Levy. I appreciate it.
Sure. Thanks for having me back. This is probably, I like talking about sleep. I like treating sleep and all that good stuff, but I do love patients in pain. Not to be morbid, but because, once you start wheedling through the symptoms and getting to the source of the pain, you can fix that, right?
Yep.
Instead of symptom treating and Band-Aid treating. So TMD is temporomandibular disorder. TMJ is what people kind of refer to it as, but really that's just talking about the joint where the bone meets the skull. It's not actually a diagnosis. TMJD is temporomandibular joint disorder. But technically the diagnoses for at least my patients are more along the lines of capsulitis and myositis and cervicalgia and myalgia, primary headaches, those types of things. Disc displacement with reduction or without reduction. TMJD is not technically the diagnosis, but it's more of the vernacular of just how we all refer to it. And so when you're talking to somebody, you're like, oh, I've got a TMJ problem. Everybody knows what that means,
Right.
So about a third of the population actually has inflammation of the joint itself.
Wow.
Yeah, it's a lot. It's a lot of people.
That's a lot.
It's a lot of people. And 98 to 99% of those people, a lot of the time when you're thinking about a jaw problem, and people say this all the time, kind of like we talked about when, your kids don't sleep and you talk about it at a birthday party or whatever, and everybody's like, oh yeah, mom don't sleep either. The same thing happens often for joint problems and facial pain and headaches. And it's like, oh, I have a migraine. Well, everybody has migraines. Well, no, they don't. Right? Like you're not supposed to. That's not not normal physiologic behavior. Right. And so what we find in a lot of our patients, and remember, our center is one of over 80 now in 7 or 8 countries. It keeps growing. Like literally every month there's a new something. Yeah. Our founder's right now, he just left Italy and now he's in somewhere else in Europe doing more presentations, trying to just bring the message. Right. And so what we find is 98, 99% of the time, jaw problems are not from this like blunt force trauma, car accident, sports injury, that kind of thing. 98, 99% of the time, and those can happen, but 98, 99% of the time, it's actually from a series of micro traumas. And so what occurs is the micro traumas are secondary to a breathing dysfunction. So it's not necessarily a sleep breathing disorder. It can be, and like 70% of the time it is, but it can also just be a functional breathing problem. I think last time we talked a little bit about head posture and how your head posture has to come forward when your breathing is dysfunctional. And so your splenius capitis, your trapezius, they all get overworked when the head comes forward. And so you add like 10 pounds for every 1 inch the head is forward of the shoulders, you add 10 pounds of postural weight to your cervical and lumbar spine. And so all of these muscles and joints are overused, overworked, exhausted. And so a lot of the time you'll hear people like, end of the day, they're like, man, my head just really hurts right here. Like you get that back of the head headache. That is all of those muscles being overused, overworked, trying to keep your head up. And so those muscles refer pain to this counteracting muscle, which refers pain here. And so
it's like muscles from your back refer pain.
Your sternocleidomastoid is the counteracting muscle to those muscles. And then you end up with pain here.
In your head. In like the temporal region of your head. Okay.
And so, And so a lot of the time, we treat sleep breathing disorders and functional breathing disorders and myofunctional disorders and early intervention and all of those things. But when you're talking about pain, it all is related to that head posture change. And typically the head posture comes forward originally because of the breathing, whether again, it's functional or sleep is irrelevant. You're almost like you're doing CPR on yourself, basically. And
so it's like your head is going forward to open up your airway.
Yeah, but in a subluxation, right?
Okay.
So those cervical vertebrae end up doing that.
Okay. So they kind of like are, I'm like trying to verbalize it for the people who can't
Yeah.
see us. So they're kind of like separating a little bit, opening
Compressing,
up,
compressing in the back.
compressing in the back. Okay.
Mhm.
Okay.
Yeah, a little bit of compression in the posterior part of the vertebrae along
Okay.
the spine. So when that happens, it ends up being this series of micro traumas to the joint itself. So I explain it to patients like if you broke a bone in your foot, you wouldn't just keep walking on it. You would
Right.
put it in a boot and
Right.
stabilize it, right?
Mhm.
Because otherwise, every single time you took a step, you would restart your healing clock. The bone would never set properly, would never heal properly because you're constantly irritating that tissue. The same thing happens in our jaw joint. But if you look at like the homunculus of what the brain's priority is for input and for compensation and for survival, the face and the jaw is a huge component of the homunculus, more so than a foot, for instance. Well, why? Because if you can't eat, you will die, right?
So basically, like your brain prioritizes your face and your head over like your back,
Over
your
like
neck,
your
all those
arm or
kinds of
your
things,
leg.
everything.
Correct.
Okay, got it.
Correct.
Got it.
Because if this bone can't move properly, well, you're going to have a real survival problem, right?
Okay.
And so what happens with those micro traumas is that over time, that repetitive injury, just like a broken bone in the foot, happens to the jaw. But in the jaw, it happens thousands of times a day because it's every single time your teeth come together. When do your teeth come together? When you talk, when you chew, when you swallow. So every single time you're doing those things, you're shoving that joint up into the irritated tissue and restarting the healing clock. So that, when it turns in from, well, inflammatory wise, I guess from a neurologic perspective is what I'm talking about, is when that inflammation reaches a certain level of brain awareness where your autonomic nervous system has to respond to that pain by compensating in other ways, then you're going to be in a state of what we call chronic dystrophy. So sympathetic dystrophy, fight or flight, running from the lion. It doesn't happen immediately. It's a gradual change over time based on the micro traumas, but everybody has a different adaptive range. And so some people never really are symptomatic or have pain, even though they might have some inflammation. But some people, it's like, no, that is horribly painful. I'm at a 7 out of 10 every single day, right? But what we found with chronic pain, and we don't talk about chronic pain like 6 days versus 6 years.
Yeah.
Time is irrelevant. There was a study done on some mice where it's always, or rats. It's always on a rodent, right? Where they put mustard oil in a molar of a rat, and then they quantified the area that was painful and the distribution of pain. And what they found was you can be actually in a state of chronic pain in 6 to 7 minutes for your brain, where your brain recognizes that as this is dystrophy, we're in fight or flight, we're running from the lion 24 hours a day. Well, that's not good just in general from a compensatory perspective, but also when you're trying to go to sleep, if you're in pain, you're never going to be able to sleep properly because your brain is still getting that signal when you're sleeping. And so a lot of the time what we'll see in patients with chronic pain or even breathing disorders, but chronic pain is what we're talking about right now, they're clenching and they're grinding. But when you're asleep, you can do that 5 times harder than you can when you're awake.
Yeah.
So your protective mechanism goes to your cerebellum, not your cerebrum. You have no idea what you're doing. And so when you're awake, you may not be injuring yourself or injuring your tissue. But when you're sleeping, you sure as heck are. And so you're putting 5 times that force or up to 5 times that force on the teeth, the bones, the muscles and ligaments. And so when you wake up, you feel like you've been in a fight.
Right.
A lot of these people wake up with headaches in this general area right here, this just temporal area, like that side of the head headache, or have just jaw fatigue and soreness.
Yeah.
And that makes sense because if all night you've been fighting your musculature and your inflammation, well, when you wake up, you're not going to feel good. You're not going to feel rested. And then coupled with, knowing that 70% of those people have a sleep disorder as well, well, then yeah, you're not going to feel good pretty much ever. Right.
Right.
And so symptom wise, obviously clenching and grinding are a big thing. But what we see when we get the patients, because a lot of the time they'll try other like spot treatments, I call them, like a Band-Aid type therapy. So I would say probably, I don't know, 75, 80% of my patients have already tried physical therapy, have already tried dry needling, have already tried Botox, have already had night guards, have already tried ortho to fix their jaw problem. And it's like, hold on a minute. We have to whittle down to the source of your jaw issue, whether that's your airway or whether that's the inflammation. It's all related, but it's all coming from here. And so, you know, when you go to chiro or you go to PT and you're like, hey, my neck hurts right here. Well, where do they work?
On the neck.
Right here.
Yeah. Yep.
But if that's a referred problem or a compensation from the airway and the jaw, you can work right here forever and ever and ever. And you're going to go back once a week for the rest of your life because you're not fixing the source of where it came from. And so, you know, that back of the head headache that I was talking about, or those muscles that are just so overworked and you got shoulder stiffness and neck pain and those types of things, 96% of the time, pain at the back of the head and the right side, not occipital cephalgia, is related to a jaw issue, and 92% on the left. So an average of 94%, where if you've got that back of the head pain, you're compensating for something. And usually, you know, and the way that we work now too doesn't help, right? Like our environment doesn't help these things. The computers don't help. The smartphones don't help, right? But we're all predisposed when we have these problems. We're predisposed to them. It's just when are the dominoes going to fall just right for us to have pain? And so, go ahead.
Okay, so something I want to ask you, and you might be planning on touching on this later, but so with an adult who has like a history of no pain there and then starts having pain can identify that this is pain. But a kid, and like you saw one of my kids recently, and y'all asked me like about pain. And the problem is like, if he's lived with this his whole life, does he even know that that's pain? Right.
So that's a great point. Because in adults, you at least have something to compare it to, right? You at least know, okay, I'm 40 and it didn't hurt this way when I was 20. Okay.
Right.
But when you're 6 or 7 and you have these issues, you don't think to necessarily tell anybody because what are you going to compare to when you were 2 or 3?
Right.
You know,
that's your norm.
You don't
your norm is being in pain.
Your normal is discomfort.
Right.
But you think that that's normal because A, it's all you've ever known, but B, nobody really is talking about it with a kid for them to be like, well, that's weird. I'm not supposed to feel like this, you know?
Right.
Or do you think that everybody feels like this because it's normal for you? And when you're a kid, your you know, general awareness of the world and that people are different is limited. Right. And that people have different symptoms and things like that. It's limited.
Right.
And so you don't think that that's weird for you because you think everybody's got it.
Right. Exactly.
And so if a kid actually is telling a parent like my head hurts or my neck hurts or something along those lines, or it hurts to open my mouth, that's a problem. And that means that, no, it actually really should be evaluated sooner. Not that they have to tell you that they're in pain because like we just said, sometimes they don't. But if they're aware enough to tell you, then it really does have to hurt.
Yes.
You know?
Yep.
But you're right. Most of the time kids aren't going to bring it up of their own accord because they don't have any
frame of reference.
Exactly.
Right.
Exactly. But if you think about from a chronic dystrophy perspective, and again, with what you do for kids, for adults, what we've found, I think I talked about this last time with the sleep, but also just from a general anxiety perspective, if you're in pain all the time, that makes you anxious, right?
Anxious or irritable.
Yeah. And so we see that so very often. And obviously we've been talking about the comorbidities of the breathing and the sleep and the pain and all those things. But yeah, you can have definite behavioral issues in kids during the daytime or at school or whatever, because they're hurting. But again, if they don't think to tell you that, then you assume it's just intrinsically a problem for them. And it's like, well, what if it's a physiologic thing that we could fix?
Right.
What if it's an orthopedic problem that we could correct? It almost like, if you think about the inflammation like this, if you had a rock in your shoe all day long, like from the minute you woke up and put your shoes on in the morning until you went to bed at night, if you had a rock in your shoe all day long, by the end of the day, you'd be in a bad mood.
Absolutely. Absolutely.
You'd be in a bad
Yep.
mood. And so the same thing happens with them, except every single time they bite down, it's injured, right?
Wow.
So, but again, compensation with the brain, your brain's like, we can't focus on that too much to tell some, to adjust or tell, we have to just compensate for it because this human being still has to exist in the world and we have to survive.
Right.
And so we're not going to maybe change our gait like you would with a rock in your shoe. You just have to power through it.
Right.
Because how are you going to eat? How are you going to communicate with your parents?
If you have a kid, I mean, I kind of like know now what to look for, but so if you have a kid, a 6-7-year-old kid, let's say, right, who doesn't have a frame of reference for chronic pain, so they're not reporting pain to you, how would you know that like they could have TMD?
Yeah. So we have the centers use, and I help with a course. We're actually trying to work on some research for it also for validation purposes, but there's something called motor nerve reflex testing. So autonomic motor nerve reflex testing, where it's not muscle testing. It is truly a nervous system response to the input. And basically what we're asking the brain when we're doing this, and it's all non-invasive. You watched it recently. It's all non-invasive, but we're asking the brain, is there something that you're focusing on basically that's putting you in a state of chronic dystrophy? And it doesn't have to be this. There's a bunch of tests, right? So I can test for carpal tunnel issues and foot issues and whatever, and then be able to refer that person to the appropriate provider if their clenching is coming from their wrist. I don't treat wrists, but I know people who do, right? And so sometimes clenching and grinding can happen because there's something else in your body that your brain's focusing on and you're just tense. But I do treat facial pain and I do treat jaw issues. And so if that is the primary problem, that's what we're asking the brain is, what is your primary source of dystrophy? What's the primary thing you're concerned about? And there may be other things, especially in adults. We see it often. Like if I tested for every single thing in an adult, I'd find more than one problem. Okay.
Yeah.
But they don't matter if the brain isn't worried about them. Because most of the time, once you fix the primary thing, everything else starts to trickle down and work itself out. Most of the time.
So so I like give you permission to use my son as an example, just to like explain to people, because I have to tell y'all, like watching what you did during this exam, I was like, in my head, I was like, whoa. Like, this is so wild. I've never seen anything like it. I had to like immediately go home and tell my husband, like describe it to him. Cause it was so cool. Can you describe, like, if you can remember your exam with him, like what you were seeing and like how you knew that there was a jaw issue?
So you don't always know that there's a jaw issue.
Okay.
Right. You can be suspicious just based on symptoms and based on other things.
Right.
You don't always know. With your son, what we were really talking about initially was his sleep quality, right?
Yeah.
And so just knowing that there's that high comorbidity of if the sleep is poor, there's probably some sort of inflammation. So then we had to figure out, is there a priority for the brain for dystrophy? And so what we haven't done yet, which I think we're scheduled to do in a few weeks, but we haven't done yet, is like the full exam where we have, the CT imaging so I can look at the quality of the bone. We see, 12, 13-year-olds sometimes with arthritic changes to their jaw joint.
Wow.
So you don't have to be like 50 to be arthritic, So we do a CT scan of the head to make sure the jaws look morphologically relatively normal. We look at the whole airway, right? We do some more photos, postural photos, intraoral photos, a joint vibration analysis where we put 2 little microphones. And we do this for adults too. Like everything I'm saying is both a joint vibration analysis that goes over the condyles of the lower jaw. And we open and close with a little image on the computer. And then it grabs the mobility of the tissue in there. We do muscle palpations, which we haven't done yet. That is actually probably the best kind of tell for patients and for parents. Whether you're an adult patient coming in or, you bring in your 10-year-old and you're like, what's going on here, right? The motor nerve testing is super helpful for me to figure out what the nervous system is doing. Yeah. But the muscle palpations are very telling for the patient or the family because what I usually do, especially with the kids, is I'll have them sitting facing their parents. And I don't like the pain scale in the sense that it can always be worse, right? Like I feel like that as a patient too. I'm like, well, you could cut my leg off. Like, you know what I mean? Like, it could always be worse. So I don't like the pain scale in the traditional sense. How we do it is it's a 0 to 3 scale, and we use a part of the body as a control that we know doesn't hurt.
Okay.
So like we'll push on their arm.
Right.
Be like, okay, this should be normal. This should be a 0. You know I'm pushing on you, but it's not uncomfortable. You're not trying to pull away from me. It's not a big deal. We then, once we have the control, they can kind of rate their pain when I'm pushing on muscles and ligaments in their head and neck, rate their pain for what the arm felt like compared to what the arm felt like. But in little kids, again, because they don't have a ton of life experience with this, right? A lot of the time, I'm also just looking at body language. So I do the small child exams. I mean, obviously the parents are always in the room, but I do this part with the kid facing the parent. Okay. So that they can also see their facial expression. Because sometimes I'm pushing on certain landmarks and they're like, and the mom is freaking out. Like, you never told me this hurt. You never told me this hurt. And it's like, they weren't going to. Okay. It's fine. Right. But we need to know that these are things that are dysfunctional. Right. And the other important thing when we're doing those is from a myofunctional perspective, especially in the kids, my myofunctional therapist is right there watching the muscle palpation. So when she's doing myofunctional therapy, she knows what muscles are pain and what muscles are going to be dysfunctional. So that's super helpful. But we have to diagnose jaw issues based on the nervous system, obviously, the symptoms of what you're dealing with, but mostly the nervous system and the imaging, to see, okay, how do we put this puzzle together? And like I said, especially in adults, they've already tried a bunch of stuff. And we talked about a little bit before, doing ortho to fix a jaw problem. I saw a patient yesterday an adult patient for a consult who was finishing up orthodontic treatment. He's had what he has been told by another provider was a TMD issue for years. And then somebody did orthodontic treatment on him. And it's like, okay, well, why? Why would you move teeth around on an unstable foundation? Right. That doesn't make sense at all. Right. Right. A, I could make the jaw problem worse, but B, that's just not stable. So then once you're done the ortho treatment, the function is still poor. And the reason the teeth were crooked in the first place is because the function was poor. So then you're just going to go right back to where you started. So my patient today, my consult today, also an adult, was like, I want to fix my teeth. Well, he has facial pain. Well, okay, then that becomes the priority. I understand aesthetically you want to rotate some stuff, fix some stuff, whatever, and I'm down for it. I like when teeth are pretty and straight. I appreciate that. But we have to do it in a hierarchy of priority and triage what is actually your problem, right? Because if I don't fix the reason the teeth were crooked and I only fix the tooth position, where's that going to leave you? Same thing with Botox, same thing with night guards. And actually, night guards, again, we talked about the overlapping sleep and pain symptoms. Night guards are given to a ton of people by general dentists for grinding. Well, 40% of the time, they make people 50% worse. Why? Really? That's what the research shows. So why? Why are we going to continue to do this? And the reason is because we're like, oh, protect the enamel, protect the enamel. It's like, yes, I want to protect the enamel as much as the next person. I'm still a dentist. Okay. Still appreciate the enamel. But the reason that it's making 40% of people 50% worse is because 70% of the people in pain have a sleep problem. And so then you're putting this piece of plastic in their mouth at a non-neurologic position. Yeah. And so the neurology that we were talking about and the motor nerve testing and figuring out what the brain's priority is, but also where the brain is neurologically neutral is important. Yeah. And so nobody's totally symmetrical. Jaws are a little bit crooked all the time. And so the bite position that we take is 3-dimensional. So it's correcting the roll, the pitch, and the yaw of the mandible so that both sides of the jaw, because it's 2 joints, 1 bone, right? So you have to manage them both at the same time. So I have to correct both sides in a 3-dimensional way to make them neurologically neutral. Right. But a night guard is linear. And so it's just taking whatever crooked space you have and just exacerbating it.
Oh,
And
wow.
so too much is not good for your nervous system. Too little is not good for your nervous system. You have to hit it just right. And, I was using the popsicle sticks, which I just kind of show you quick the test. If I had put extra, he would have failed. If I would have not put enough, he would have failed, right? Like there's a sweet spot to what your brain is comfortable existing in, what space it's comfortable existing in. And so that's the place that we want to build in a kid, their whole development. But in an adult, that's the place where we heal them. And so, and I mean, you heal it in kids too, but that's the important thing to remember, is that we're always looking at how is the nervous system responding, because that's going to tell us if it's an effective position for the jaw or not. And so that's why when we have people who come in with all of this history of all these things, or Botox, my biggest problem with Botox is not that it doesn't help your symptoms, because sure, it keeps the muscles from, clenching and stuff, but it lets the pathology or the arthritis or the, degeneration of the condyle progress basically unchecked.
So it masks it.
100%. Yeah. And so you can get a relief of symptoms, but we see patients a lot of the time, if patients have done Botox for years and years and years, and then they come in and we take their scans and we look at all their imaging and stuff, and it's like, your condyles are a disaster from a bone perspective, because we fixed the muscular contraction with the Botox, but the actual inflammation in the joint space that's deteriorating that bone was just left alone.
Wow.
And so then that just keeps going. Well, what does bone do in the presence of inflammation? It resorbs.
Yeah.
So then we have a true bony degeneration that could have probably been prevented if we had treated the source in the beginning.
Okay. So, to go back, I'll try to you what I saw, but then you explain what actually happened during this exam, because I just thought it was so cool. So basically you had him stand up, and you're looking at him from the front and from the side, and you could tell that his, what do you call it? His head was forward head posture. Okay. So his head was pushed forward when he's just standing normally. Okay. And then you had him put his hands out in front of him, his elbows to his sides and his hands out in front of him. And you had him, you put your hands on his forearms, and you had him push against you, push his arms out. And he was not super strong doing that, right?
Correct. So
even though my kid is tough as nails.
I was provocating his deep radial nerve. So that is what gets impinged in that brachial plexus out of C5, 6, 7, right? So
okay.
If the forward head posture is impinging it, that's going to be inflamed.
And then you, was that when you did the tongue depressor?
Yeah. So I had him count for me to see how his jaw was moving. Yeah.
Okay. And then she put a tongue depressor between his teeth and had him bite down on it, and had him again push his arms out, and he was way stronger doing that. It was the weirdest thing I've ever seen. So weird.
The tongue depressors again are linear, so similar to the night guard, we can't use that for forever. It's good to test the nervous system and see kind of where we're at, but not for treatment. So treatment would be in a 3-dimensional rotational way.
Right.
Yeah.
Right. So that test was just telling you
that there's inflammation.
There's inflammation.
And then as soon as we decompressed that jaw joint by just putting something in between his teeth so he couldn't overclose.
Right.
As soon as we did that, this inflammation decreased enough without the pressure of the condyle that his brain was like, oh, great, I don't have to worry about this anymore. And gets his head up slightly, right? Helps with the posture slightly. And the other thing with forward head posture that we didn't talk about, but I think is worth mentioning, is, and we get more of this at the data collection appointment, but we do this again, kids and adults, it's all, similar, is when the head posture comes forward, everything rotates. The spine has to rotate. So then we get one shoulder that's a little higher than another. We get one hip that's a little higher than another. When your kid's 12 and they go to the pediatrician says they have scoliosis. Well, do they have scoliosis legitimately, or is it the way that they had to grow because their head was forward?
Yeah.
Right.
And wait, there was something with the position of his feet. Did that make a difference?
Yes. Yeah. They were divergent.
So he's pigeon-toed.
Opposite.
Yeah.
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 Because that is a better balance when your head is forward. It's almost like if you're skiing, right?
So interesting. It's so interesting. And like, just so that people know, like, my child has never ever, and he's only 7, so he has never once complained about jaw pain.
Mm-hmm.
He has never once complained about a headache ever in his life. I just happened to bend Dr. Levy's ear about him and was like, because my only thing that I knew for sure is that when he wakes up in the morning, he is like a bear. Like, he's so irritable in the mornings.
Mm-hmm.
And so I was like, let's just like see if something's wrong. And lo and behold,
Yeah.
he does have stuff going on.
Yeah. Yeah. And that happens, like we said, it happens a lot. Happens a lot in kids, less so. I mean, like I said, adults know that they hurt, right?
Yeah.
They know that
Yep.
they know that their face hurts or their head hurts or they wake up with headaches or whatever. But there are other symptoms that outside of jaw pain that I think are kind of worth mentioning. Actually, my patient today had one of them. And my patient yesterday had another. Common symptoms: ear pain, ringing in the ears, stuffiness in the ears, or like feeling underwater.
Okay.
That is a super common complaint of patients with
Okay.
TMD. And most of them have already gone to the ENT, and the ENT is like, there's nothing wrong with your ear. Your ear is normal, right?
Yeah.
So it's like, okay, well then what else is it? But the temporal bone that separates the jaw from the inner ear is super thin. And there's a remnant of a ligament that runs from the back of the disc. The retrodiscal ligament runs from the back of the disc through a fissure in the temporal bone into the inner ear.
Okay.
So if there's inflammation in that area that's impinging on that remnant of the ligament, then yeah, your ear is going to have some symptoms, right?
Yeah.
We also see like excessive production of earwax as a clenching and grinding. My patient today had that clenching and grinding symptom just because of all the inflammation in that area and the irritation. You're going to produce more earwax. So things like that people don't necessarily think are related or, part of the problem, part of the equation. Ringing in the ears is a huge one. It's also probably one of the most annoying ones for patients to deal with.
Yeah.
That'll drive you nuts,
Yes, literally.
And yeah. And so that's unfortunately usually a later stage symptom because of the way the ligaments are stretched at that point. But it doesn't mean that you can't get improvement and get, some people it goes away completely. Some people we have to do a few different things to try to support the ligaments and the inflammation and all those things. But those are significant. We see that a lot in our TMJ patients. Obviously, pain when we chew, pain or difficulty when you're opening and closing the mouth, or a limited opening where you feel like you kind of get stuck when you're going to open, jaw popping and noises. The noises,
I was just about to ask you that.
Yeah. The noises by themselves don't freak me out. But if they're in the presence of inflammation, that's a problem. And so but you wouldn't know that unless you tested for it. Does that make sense? And so the jaw popping and noises, basically what that means is that when your teeth are together, if you open and it pops, then your jaw is dislocated when your teeth are together. Just like you would dislocate a shoulder. Right. But again, your brain does not register this. If you dislocated your shoulder, you'd be screaming in pain, right?
Yeah. Yeah.
You're going to compensate for that because you still have to function. You still have to talk. You still have to eat, or you won't survive. Right. Right. And so it's just the hierarchy of pain for the brain and like we talked about the homunculus, what it's really going to focus on and what it's like, we don't have time for this because this person's going to die, Right. Neck pain. We talked a little bit about that with the occipital cephalgia. That's a huge one from the forward head posture perspective and just the fatigue of those muscles. Same thing with the shoulder, stiffness and pain in the shoulders or like knots in the shoulders, very common because the trapezius is like a bat wing, right? And so that's a big one. Headaches, temporal headaches, tension type headaches, occipital headaches, migraines, all of those are related to inflammation in the jaw joint and the head posture and all of those things. And so we ask a lot of questions about headaches in our intake paperwork. When do you get them? Where are they? What's the intensity? How often does it happen? All of these things. Women, it's a little different. I have a patient I'm treating right now who we fixed a lot of her headache problem, but she still gets migraines just based on her cycle. And so, sometimes that happens. And so I actually was at a lecture on that, I don't know, in August maybe. And so we're using some of the things I've found in that lecture to try to pinpoint, but that's also where functional medicine comes in. And where we're like, hey, we have a great functional medicine doctor that we work with, and I think you need to get your hormones checked too. Right. Because orthopedically I've stabilized you and I can give you some supplements and things like that. But if your hormones are out of whack, your hormones are out of whack,
Right.
And so sometimes we have to talk about those kinds of things. There's an osteopath that I work with, who's fantastic. And she's actually come with me. My functional medicine doctor and my osteopath actually have come with me to the motor nerve course for the triage of pain. So they can understand kind of what, and I've treated the functional medicine's family members and the osteopath's family members. And so everybody's on the same page, you know what I mean? Which I think is super important when you're like, okay, I've done everything I can do. You need to work on the fascia, work on the cranial movements, work on the hormones, whatever that is.
Right.
We talked about shoulder pain, clenching and grinding, huge. We talked about that a lot. Changes in the bite are also a big one for patients.
Yeah.
Not necessarily like the teeth are shifting or crowding, but that like the way your teeth come together feels different than it did. And so it kind of goes back to the difficulty in opening and closing, but it's like a shifting almost. And then numbness and tingling in the fingers or the hands. Big one. But again, with the brachial plexus and the forward head posture, if those nerves are impinged, a lot of the time it'll lead to some numbing and tingling in the fingers. And my patient yesterday had that. So they're all common things, but not everybody's going to have every single thing. Right. And I mean, these are like the ones I just went through are kind of like my top few. But like I said, if you're in chronic dystrophy, there are a bunch of things that, low back pain is another one that we see commonly in TMD because of the way that we breathe, because of that lumbar spine and the forward head posture. So there's so many kind of nuanced symptoms that people have. And then they end up, like we talked about at Chiro, or they end up at PT or whatever. And not that those things are bad. They will help, but only in a short term.
Right. It's not addressing the source,
right? Because we're not fixing where it's coming from. So you get adjusted, maybe at the chiropractor, you feel better for a few minutes. You walk to your car, you touch your teeth together again, you injure the joint, and you're going to fall apart back into your compensation.
Right. Okay. Well, you're going to have to come back for a round 3 because we didn't get to talk about the other stuff. It's always like so much comes up and it's just like so fascinating and we don't have enough time. So
it's all good.
After we hang up, we're booking round 3.
All good.
Okay. Well, Dr. Levy, thank you so much for coming and talking to us about this. And remind everybody how they can find you.
Yeah. So our office is the TMJ and Sleep Therapy Center of New Orleans. We are in Metairie on 3101 7th Street, right off of Causeway behind the Toyota dealership. Our phone number is 504-832-2222. Our website is tmjsleepnola.com. And our Instagram is at tmjsleepnola.
And y'all will see people, whether they're from New Orleans, Louisiana, or somewhere else.
I have patients from all over right now. I have patients from Texas, Mississippi, Alabama, Georgia, and Florida right now.
There you go.
So they come from all over. And Mexico. Right. I got a Mexico one recently. I was like,
amazing.
What? She comes here on work sometimes. So I was like, that's fun. That's cool.
So even if you don't live in the New Orleans area,
but there is a directory also though, like for people who, maybe truly like across the country or something, there is a directory on TMJ Therapy Center, CENTRE.com. There's a directory with all of our centers listed. Like I said, there's over 80 of them now. And so if you really are across the country, they do have people closer to you, I am certain.
Yes.
In the US and Canada for sure, that may be more convenient, Yeah.
Okay. All right. Well, thank you, Dr. Levy.
Thank you so much again. Good talking with you.
All right. Bye.
Bye.
Thank you for tuning in to this episode of the Little Brain Campaign podcast. If you enjoyed our conversation, give us a follow on your favorite podcast platform so you never miss an episode. Please take a moment to leave a review while you're still thinking about it. It really helps grow the podcast, and I love hearing from our listeners. See you next time.